BBC Sounds. Music, radio, podcasts.
Hello there and welcome to the Inside Health Podcast. I'm James Gallagher. Now we're going to explore a transformative discovery about how cancers develop and bring some much needed clarity to the confusion around a common form of antidepressant. But first, I want you to meet Pam because she's something of a pioneer.
I'm 74 now. I have a complex medical history. So being able to look on my medical records, I feel very fortunate. And to be honest, because I've had it for so long, I thought by now everybody must have it. And now technology is advanced, me included. I can look at it on my phone as well. I'm pressing on the app and I'm just waiting now for it to come through. View my medical records. So I've got a choice now. Consultations, medications, immunisations, results and letters. So if I want to say about medications and order a prescription, I can just tap on medication and they send it through to the chemist. And so I'm in control of my own health.
Well, that's Pam, but if you or I want to see our GP medical records, well, quite frankly, it can be a bit of a pain. We've got to go through the process of requesting them and then waiting for them to be prepared. But Pam has instant access literally at her fingertips and has done for the past 15 years just because her surgery thought it was an important thing to do. Well, very soon, most people in England are going to be like Pam. The 1st of November is NHS England's big flipping of the switch. And from that point on, all new GP records will be there waiting for you on the NHS app. Scotland, Wales and Northern Ireland, well, they're sticking with the old scheme for now. We're going to speak to Pam's doctor who's pioneered this in a moment, and he has some quite big reservations about what NHS England's doing. But first, I'm joined by Dr Navjoyt Lada, who's clinical editor at the British Medical Journal and a GP. Hello, Navjoyt.
Hi, James. Thanks for having me.
So can you tell me what this big idea is around GP medical records?
Yes. At the moment, patients are able to request access to their historical medical record by asking for that to be made available. The main change is that for a lot of patients in England, this is going to be the default, where you will be able to see notes made by healthcare staff when you have an appointment with the GP or the practice nurse, your list of medications, the results of any tests or investigations that you've had that have been requested. All of this will be available to you by default rather than you having to request it.
And Navjoyt, how do we actually get hold of that information?
A lot of this will be through the NHS app, plus other patient-facing apps that GP surgeries use that link in with the medical record and can offer this information up. But largely it will be coordinated through the NHS app.
I can see things like blood pressure recordings of some blood tests that I've had already on there. But it sounds like the big difference is that if I was in your practice, Navjoyt, and you're typing away, I can see everything you're typing.
Exactly, yeah. So the notes that I'm making about whatever we're discussing in that consultation, you'll be able to see them just as they've been typed up.
Why is this a good idea?
The studies that have been done in places where access to health records is already happening suggest that people feel more confident, more prepared to manage their own health. They understand the plans better and can clarify them more easily. They're better at taking their medications as prescribed. So that's all really good. And it all fits with this overarching plan, I guess, from the health system that helping people feel more able to manage and be in control of their health is good for people.
Without being rude, Navjoyt, are your notes understandable to the general public? They're not full of doctor speak.
Well, I mean, this is a concern. So at the moment, the notes I make provide a sort of summary of what was discussed, but also there are other things that we're thinking about. You know, if I'm going to be sued, have I made adequate notes that kind of cover exactly what was discussed? But also in quite a time-pressured consultation, we've got 10 minutes to see a patient and to write up the notes. Often we're using shorthand, abbreviations, maybe medical terminology that isn't always understood by a patient. So that's definitely going to be a shift in how we record our notes to make sure that they are understandable, they cover enough of what was discussed. You know, we aren't using medical jargon that might confuse people.
Yeah, I remember earlier this year we made an episode about medical language and how some words mean something very different to doctors and the medical professionals than they do to everybody else in the general public. So if I turned up and I'm complaining of a sore throat, that means something different to you, whereas to me, doesn't it?
Exactly that kind of thing. There is potential to be pulled up on a lot of that language that perhaps, from that piece, doctors might not even realise the kind of impact that some of that wording has.
And are there any other challenges to making GP records automatically available to people?
Well, I think there are legitimate concerns, probably not about the principle of making records available, but more about how it's being implemented, in my view. So one of them is that it's not going to be appropriate for everybody to be able to have access or indeed safe. So people who are vulnerable, people who don't have capacity to manage their own healthcare. So for those patients, there are plans for how to mitigate the potential harms and maybe block information from the medical record, or practices can remove the access. But that's not always easy to implement in practice. Practices may not always be aware of an individual patient's situation. It takes time to go through the records and select those patients as well. So that's a concern for sure.
And Navjot, has anyone tried to do this already? That we can kind of see how well this does work?
Yes, NHS England have been piloting this in a few practices, but there are practices who've been doing this for much longer and really kind of blazing a trail on this.
Hi, I'm Amir Hanan. I'm a full-time general practitioner working in Manchester and have been giving patients access to the full electronic health record since 2004.
Hi, Amir. Welcome to the programme.
Thank you for inviting me.
What I want to know is why, nearly 2 decades ago, did you go, we need to be giving patients access to all this information?
I've always felt that there was nothing that I wanted to hide from patients. I wanted them to be able to see the same information as I can, because I recognise they'll get a better understanding of their healthcare needs, that they felt more in control of their own health.
So literally, Amir, what can you see?
You can see what medications you're on, what allergies you've had. You can see consultations that you've had. You can see test results. You can see letters from the hospital.
And I can imagine that there are times when that would be quite useful, because sometimes a GP appointment can be a bit intense, particularly if it's something quite big that you're discussing. And actually, sometimes by the time you're out the door, you've forgotten it.
You have. And the evidence shows that people only remember 10% of what's been said as soon as they walk out of the consulting room, which is why the ability to be able to read everything that your doctor or nurse has written about you is so helpful.
I'm suddenly, and this may be completely wrong, say I was having a sample of a lump being analysed. Is there any scenario where, say it goes to a laboratory that analyses it and that the letter's sent to you, can I see that letter before it's been explained to me that that could be cancer?
Absolutely, and it was one of the worries I had before I started giving patients access to the medical records. There may well be a situation where I have a blood test or an X-ray that suggests something that could be serious, and we need to prepare patients for that. One of the hardest things I have to do is break bad news. But what I also recognized was breaking it late is even worse. And that's why I wanted patients to be able to see their test results, warn them that there's a possibility that they may see something that might upset them, but then let them make the decision about whether they choose to look at that information or whether they choose not to, and instead contact the GP practice and speak to us. And I do this before I grant patients access to the medical records.
That is you being very considerate about any potential consequences of opening up this information. What is being proposed for NHS England is that everybody, just by default, will now have access.
And it's for that reason that I don't feel it is safe to do this without the person having an opportunity to have considered these risks beforehand. So in our practice, we ask everyone to complete a questionnaire before they're granted access. And one of the questions we ask is that if you read something that perhaps upsets you or you don't understand, what would you do? And you're given options, which might include, I'd wait until I've seen the doctor. I might panic or get worked up. I might choose to look at the practice website to see information on there to help me understand it. I might choose to wait and speak to the doctor when the next available appointment is. I might choose to ring 111, call the out of hours, or go to casualty. It's an opportunity for patients to think about these things before it happens, because we don't want people going to A&E, but we don't want people to panic either. It's about making an informed choice, and that's really what I'm keen on, and not just thrust on somebody without being prepared for it.
In your 18 years of doing this, Amir, have there been any times when things have gone wrong?
I wouldn't say gone wrong, but rather that things have happened that were unexpected for the patient. For example, things that they don't understand, letters that they've seen about somebody else perhaps that have been accidentally added into their record. We have had one patient where they were in a coercive relationship where somebody else was controlling them, and they'd gone even as far as insisting that they get access to the records. And clearly that became a very dangerous situation because they could now no longer talk to the doctor freely, knowing that their partner would find out about it. The important thing is, though, as soon as this became known to us, we were able to switch off the access. But our biggest problem has really been simply people not knowing that they can have full access to the medical records, and also technical issues such as people not being able to download the app or registering or knowing what to do if it stops working for them.
And because this obviously relies on technology, is there a technological divide here? Older generations not getting the same access?
My own experience is that we've had right through to people over 100 years of age who've got full access to the medical records. It's much more about the support that is provided either by ourselves, by family. So you can have proxy access where you might do it on behalf of your grandmother or parents if they give you permission to do so.
I don't have a problem too much with technology unless it gets really complicated, but this was simple. Some people found it hard, but the assistance was there because we'd formed like a patient assist group, so we could help each other without actually seeing each other's information. I think that a lot of people found it easy once they got into it.
Now, Amir, what if English isn't your first language? What if you have learning disabilities? You can see how many people would be left behind too.
You're right. When I first started, I was offering the service to everybody, and I realised that there were certain groups of people that were less likely to sign up for access, such as those with learning disability or those who don't speak English. What I then did was put extra support in for those patients by proactively contacting them, explaining to them what the benefits are and asking them if they'd like more help or if they've got a family member or a carer that could help them to do it on their behalf, so long as they gave consent for that.
My name is Roswanna and my parents are originally from Bangladesh. They've come to this country at a young age but was unable to carry out education. That created a lot of barriers in their communication with many things, and still today it's been a particular problem around their health, especially with my father having many health issues, being high blood pressure, high cholesterol and chronic pains. It has put him in a vulnerable category, I'd say, where he's not able to communicate the correct information for him to get seen in the correct way, and his mental health wasn't at the best because he was in constant pain. He wasn't able to do his everyday things, not being able to communicate his needs to the practice, to the doctors. It was only recently that I got myself onto the patient access through the advice of the doctor at the surgery. When my father's pain does increase and he's having more bad days than good days with his medication or not knowing what's going on, I'm able to just go on the app, and if I am needing an appointment for him, it's as quick as just pressing the option. And with prescriptions, we're able to just put in a little message to ask if it is possible for him to have a stronger painkiller. So having that query put in, you'd get a response back straight to your mobile phone to say they've approved of a higher dose or if he needs a review with the doctor.
So, Amir, just listen to Roswanna there. You can hear the benefit for some people of having access to these GP records. But are you happy with what's going ahead with NHS England, this idea that everybody gets automatic access to all future records?
Whilst I believe that it's really important that patients do access their medical records, the first principle that we subscribe to is to first do no harm. I do not believe it is safe for us to switch on the access without those checks and balances in place. I've mentioned the questionnaire that everyone should complete beforehand. And really the questionnaire is an opportunity to discuss with the practice what's going to happen, what's right for you. That doesn't happen with the current proposal. And for that reason, I don't believe it's safe.
So just walk me through, what are the scenarios that make it unsafe?
So patients with severe mental illness may act differently when they look at their medical record to someone who's mentally stable, if you like. Secondly, if you're under safeguarding or child protection, that individual may potentially put themselves at risk if they read things that the health professionals have been writing, because sometimes as health professionals, we aren't absolutely certain about things and we need to be able to share information. There are systems in place that can prevent the patient from reading what the clinician has written, but that's open to human error. We're still training staff on how to do it. This is not the right time to switch on for everybody. But I do believe that we should start doing it in a controlled way, where patients choose to have this and extra resources are put in place so that we don't leave anyone behind.
Thank you to Dr. Amir Hanan there. So he's been giving patients direct access to their records for nearly 2 decades, but says NHS England's plans are not safe. Well, in response, NHS England told us that giving access gives patients the tools they need to better manage their own health and to reduce pressure on GP practices. And they go on to say that general practices were told in July what they needed to do to safeguard people, with patients having the ability to opt out. Well, let's leave that there because I do want to turn now to antidepressants. You've probably heard of serotonin. It's a chemical that helps brain cells communicate with each other, and it's involved in our mood. Well, a recent study concluded that low levels of serotonin were not the cause of depression. So far, no controversy. But some people overinterpreted those findings and claimed a whole class of antidepressants were a total waste of time. They're called selective serotonin reuptake inhibitors, or SSRIs for short, and they work by boosting the amount of serotonin in the brain. Let's clear this all up with Dr. Navjoyt Lada. Hello again.
Hi.
So have you had anybody coming to you off the back of this story going, are my antidepressants not working?
Yeah, so I have. People have wondered, I've heard my antidepressants have serotonin in the name. Does that mean they're not going to work or they're not effective?
So I think we need to unpick the study. What did it actually show?
The study was what we call a systematic review of other studies. So it was gathering together all the published studies on the question of whether depressed people have different levels of serotonin. And what it found is that they don't, that low serotonin levels are not associated with depression. And what the study authors said is that this refutes the idea that depression is due to a chemical imbalance in serotonin.
And that was one of the big ideas about why some people end up with depression.
Yeah, and I think you've used a key word there, which is one of the ideas. You know, big bodies like the Royal College of Psychiatry and other research has already suggested that depression is not as simple as one chemical imbalance. And this study supports that idea that it's not just merely a chemical imbalance.
But that kind of finding snowballed quite a lot, though, didn't it, Navjoyt? Because what started off as a study showing that low levels of serotonin in the brain wasn't directly causing depression, that became, well, you know, all those drugs that boost serotonin levels, well, they don't work now.
Yeah, exactly. You know, it's important to point out that that's a completely different question than what was addressed in the study of whether or not antidepressants work.
The best comparison I saw was from one psychiatrist who described it as like, headaches aren't caused by a lack of paracetamol in the brain, but you still take paracetamol if you've got a headache.
Yeah, exactly. That's a really good analogy. And actually, that's true for a lot of different kind of conditions. The treatments we take aren't necessarily targeted at one specific pathway that we know of, but the medications might still be helpful. And so for the people who asked me, does this mean that my antidepressants don't work? What I said to them was that what we know about depression is that there are multiple possible treatments. And if your antidepressants are working for you, then in consultation with your doctor, keep taking them.
It is an important and big question, though, isn't it, about how well antidepressants work, including those that act on serotonin?
Certainly, there have been many studies and trials that are trying to unpick their effectiveness. You know, there've been, in some cases, questions about the quality of some of the studies and the availability of all the trial data. But our best available evidence suggests that certainly for severe depression, they are helpful. For mild and moderate depression, it's a bit less clear. And there may be specific patients in which we're also less certain about their use, but they are certainly an option in many people.
Do you know how we ended up prescribing these drugs that act on serotonin for depression? Because obviously it didn't come from people going, oh, people with depression have low levels in the brain, let's give drugs that allow the serotonin to persist longer. Where did it come from?
There has always been a suggestion that serotonin is implicated in the pathway somehow. So not necessarily that the overall levels are imbalanced, although, that was an idea at one time, but serotonin has a role in how our nerve pathways work. And even if the levels aren't different, that might still be one of the pathways involved in depression. And so serotonin and medications that kind of target serotonin were identified as a possible candidate drug for addressing some aspect of depression, even if we weren't fully clear on exactly the pathway for that.
So Navjot, in case we've confused or lost anybody on what they should be doing, if you're taking antidepressants today and you've heard all of this, should you be stopping?
No, would be my answer to that. I don't think this study is a reason to stop taking antidepressants. And if they're working, they're working. If anybody listening has any questions or has been thinking about, stopping their antidepressants, I would say we know that with these selective serotonin reuptake inhibitors, they're not safe to just stop completely. So I would always say that's a conversation to have with the prescribing doctor.
Navjot, thank you so much for coming on.
Thanks very much, James.
Now, right at the beginning, I promised a breakthrough in understanding cancer. Now, the cause of many people's tumours goes completely unexplained, and we're going to hear from one in a minute. Kelly Harrop, she was diagnosed with lung cancer when she was 40, despite never smoking. So let's jump straight into the science of this with researcher Dr. Amelia Lim from the Francis Crick Institute.
Thank you so much for having me.
I always thought that cancer started off as a completely healthy cell, and it got mutated and mutated and mutated until the DNA became so corrupted that it just divided uncontrollably, and that would grow and grow and grow, and that's what we would call a cancer. But more complicated than that?
Yeah, so you're absolutely right. So yes, cancer does grow due to lots of mutations accumulating over time, but that's not the only model that's out there. There's also the promotion model.
So this is what your interesting study has started to unpick, these cancers that arise through this different route, and you were looking at air pollution.
Yeah, so our interest in this project actually started with lung cancers in never smokers. So when you first think about lung cancer, you think, oh, it's associated with smoking. But actually, there are 15% of lung cancer cases that occur in never smokers. And if you consider lung cancers in never smokers as a separate entity, it's actually the 8th most common cause of cancer death in the UK.
So even though we just go lung cancer smoking, there's a huge number of people that get lung cancer who've never smoked.
Exactly.
I was first diagnosed in December 2015. They ended up taking a third of my right lung away and quite a few lymph nodes as well with it.
Crikey, so quite a bit of surgery.
Yes.
How did that feel being the person that has never smoked and had lung cancer?
It was quite a shock, really, because naively I thought only smokers really could get lung cancer, or unless you worked in a smoky environment and things like that. I was just like, well, I've never smoked, so why have I got lung cancer?
When you said you had lung cancer to other people, did everyone assume that it was related to smoking?
Yeah, I have to tell everybody that I've never smoked is kind of the first words that come out of my mouth, really. Because everybody just thinks, oh, she's a smoker,
Well, I'm glad they caught it and everything's okay now. Thanks, Kelly.
Thank you very much.
So these were the cases that we were concerned about. What were the mechanisms? What were the risk factors that were associated with this group? And we actually found that air pollution was associated with lung cancer incidents here in the UK, in Asia, and across the world as well. So we started to investigate how this could be related to lung cancer development specifically in this case.
So you've got areas of the world where you've got high levels of air pollution, or regions or streets, and that's where you're seeing more of these lung cancers that have got nothing to do with smoking. So you've got an idea that air pollution's doing something. What's it doing?
Yes, exactly. So that's what we wanted to figure out. So what we did then was we went to the lab and we have mouse models, and we also collaborated with this other lab in Canada where they had these human studies. And in both cases, exposing the mice and the humans to air pollution to observe for changes in the lungs to see what exactly air pollution was doing.
Now, I'm going to give half a spoiler away, because the spoiler is it's not doing the same as what something like tobacco smoke does. It's not mutating the cells in your lungs like crazy so that they eventually become cancerous cells. Is it? It's doing something subtly different to lead to cancer.
Yes, absolutely. So we actually did not see a significant increase in the numbers of mutations, but instead we saw things like an increase in inflammation, specific genes that were related to inflammation, creating this conducive environment within our lung cells.
So, Amelia, explain for me then this idea of how inflammation caused by air pollution leads to a cancer.
Right. In our lungs, we actually may have these cells that are actually sleeping, but they might have one mutation and just sit there, and then they need an influence, such as air pollution, that creates this conducive environment that then allows it to actually wake up and actually make many, many, many copies of itself and grow into a giant tumor.
So let me get this right in my head. If you were to compare two cells, the old school of thought is that the first one could have dozens upon dozens of mutations until it tips over to become a cancer.
Yes, so that's exactly how we think about how smoking might contribute to lung cancer, is it comes by and it creates all of these mutations within a single cell, and that's what gives it the potential to make many, many, many copies of itself and grow into a giant tumor.
But you're now showing that that first cell that leads to a cancer could have just one mutation in the right place at the right time, but needs waking up to become a cancer.
Waking up with the right conditions for it then to grow.
Doesn't that mean, though, that if you looked in my lungs now, you'd find cells that, in theory, could become cancerous, could grow out of control to become a tumour?
Absolutely. So that's actually part of our study. We actually examine normal lung tissue from people who get lung cancer and don't get lung cancer. And we see that in about 16 to 19% of these cases, there are already these mutations that are there that something like pollution could act on.
It's almost like the cancer's already there, but it's just asleep and it just needs waking up.
Yes.
That sounds so simple, but that's also quite a radical idea at the same time, isn't it? Because that is not how we've been explaining how cancers form for decades.
Exactly. But the idea that pollution and smoking could contribute to lung cancer was actually proposed in 1950. But I think already at that time, there were 80% of cases that were associated with smoking. So I think scientists probably felt maybe that's the first one we should focus on. And also, DNA profiling studies had come about to create these large compendiums of all these DNA mutations. So a lot of scientists put in effort to collecting atlases of these mutations.
The era of DNA has allowed us to interrogate and find all of it.
So we've been focused on that and sort of overlooked maybe another mechanism or another model in which lung cancer could develop.
Crikey. How many times have we heard that in science, that actually something we think is radical and brand new, actually somebody came up with that?
It's always somebody else's idea, isn't it?
Yeah. But what made you look beyond that for other answers?
I think for us, we were very interested in lung cancers in never smokers, which are characterized by very few mutations.
How significant is this, do you think, beyond just air pollution? Do you think this is actually like a fundamental way in which cancers are forming in people's bodies?
I think there's definitely the potential there. It's just waiting for somebody to come by and explore it.
Amelia, thank you so much for coming in.
Thank you so much for having me.
And thank you for listening to this Inside Health podcast with me, James Gallagher. The producers were Beth Eastwood, Jerry Holt and Erica Wright. The studio manager was Jackie Marjoram. Next time, we're exploring the impact that cold weather and being unable to heat our homes has on the human body. See you then.